Thank you so much for joining us today on Wednesday, the 24th of February. I know some people, including our special guest speaker, are joining from other parts of the world. So whether it be morning, noon, or night, you're all very welcome. So without further ado, I'd like to pay special welcome to our guest speaker, Professor Stacey Van Gelderen. Prof. Van Gelderen is a nurse educator who has focused her career on building family-focused caring practices and nurses' communication strategies. Prof. Van Gelderen is the primary author of the Van Gelderen Family Care Rubric, which is an evidence-based validated tool that helps nurses develop family assessment and communication skills. And this tool has been recognized by the International Nursing Association for Clinical Simulation and Learning and was recently awarded the 2018-19 Articles of Influence by the Society for Simulation in Healthcare. The Van Gelderen Family Care Rubric is currently being utilized by healthcare staff and educators in 9 countries across the globe. Professor Van Gelderen serves on the International Family Nursing Association Education Committee and co-chairs the Simulation Technology and Informatics Subcommittee. She offers workshops and consultations for simulation, nursing education, and family practice. And indeed, first introduced to the school by our colleague, Dr. Suja Hanadan, I must say Stacey has given very generously of our time in linking with many colleagues across the school. And in fact, at the moment, we're hoping to roll out a simulation and indeed research project focused on the Van Gelderen Family Care Rubric. So I know it's very early in the morning in Minnesota. So thank you again, Stacey, for joining us. And we're all looking forward to hearing your presentation today, which of course will be recorded as well for our YouTube channel. Thank you very much, Stacey.
You're very welcome. Well, thank you for having me. I appreciate it very much. I was teasing my kids last night to remind them not to interrupt Mom up given the webinar this morning. They're all getting ready for school and it's 7 a.m. here. So hopefully I don't get any knocks at the door on my office. So, so yeah, I'm looking forward to it. So I think maybe I'll just go ahead and share my screen and kind of start the presentation here. Let's see here.
Yep, that's coming up first now. Yep.
Great. All right, so y'all can see that? Wonderful. Well, thank you again, as I said, to me and Suja and UCD for having me. It's a great privilege to just share my work with all of you. And it's been a joy those last couple years I've gotten to work with the UCD staff and glad that you're all moving forward with some research regarding the Van Gelderen Family Care Rubric. So I thought it might just be kind of helpful if I gave you just a little bit of background about myself. Sometimes when you kind of wonder, figure out what people are all about, kind of helps to understand the rubric itself and the work and kind of my journey that I've been on these last several years. So before we just kind of get into the nitty gritty, I thought just show you where I live. And I live in Minnesota, which is part of the United States. It's way on the northern end here. I live in a small town called Fairmont. And my practice has been in Fairmont and Mankato with Mayo Clinic Health Systems for the past 25 years, whether it's as a staff nurse or working as an educator with students in there. It's kind of been my primary area. So okay. I have been practicing, as I said, for about 25 years. This is our university, and this is Minnesota State University. So I work for a college, a state college, and so it's a public education place. I'm a professor, as Timmy said, and my passion is really about helping students learn family and communication and assessment skills, which you'll learn about from me today. So in 2017, the university built a state-of-the-art clinical sciences building, and we have about 15 high-fidelity mannequins that range between newborns and adults. And it starts in the first semester of the School of Nursing, where we spend a lot of time in simulation and our students learn how to take care of patients and families in this way. And this is a kind of a great place for our students to learn those skills before they take care of patients in the hospital. And we're just really proud. Our simulation center just was provisionally accredited by the Society for Simulation in Healthcare. It's really difficult to get this accreditation, and so we're pretty proud of that for our simulation center. So these are some of the spaces that we use in our simulation suite. On the left, you can see this is our home room. This is where our third semester students do their community health rotations. They learn about, how to take care of families, fall risk things, how to set medications, those kinds of things. And on the right here, this is our multi-bed skills lab, where our first semester students learn their basic skills, how to put in Foley catheters and do assessments and those kinds of things. So it's a nice flexible learning space that helps students meet their learning needs. But this particular picture is just showing you kind of like our control room, where our simulators are kind of getting their voice. This is one of our professors, Dr. Colleen Royal. She's talking for the patient. And you can see this simulators. I don't know if many of you have worked with a lot of them, but they're really can be kind of almost like a real patient, where they have lots of bells and whistles. They might you can start an IV on them. They cry, they sweat, they can bleed. You can put NG tubes down them. Just really a lot like what you would do when you're working with a patient. And so in the upper right corner here, you can see this is our obstetrical suite and our neonatal suite. And this particular mannequin has a lot of abilities to do like postpartum hemorrhage. She can birth babies, all kinds of interesting things she can do. On the lower right is our suite, where we have our neonates and our all the way up to adolescent simulators, where we house them, and the students will take care from premature all the way up to adolescent mannequins. So really a little bit of philosophy about me is that I feel that, from an education standpoint, simulation really has high value. It's a place where education can be with students or healthcare staff, where we kind of get the kinks worked out. We have that communication, we build those teamwork skills. It's a way to give formative feedback to learners and help them really achieve their best potential. And my personal philosophy is not to use simulation in a punitive way, but really just help to guide learners and their growth and development of learning skills, teamwork, communication, all those kinds of things, to really get better healthcare outcomes in the end. So our School of Nursing is really based on, not only caring for the individual patient, but really caring for the whole family unit. And so I'm really proud to say that I took the lead at our School of Nursing to build what's called the Maverick family. Our mascot at the school is called the Mavericks. So I named them the Maverick family. It's really just a fictitious 65-member simulated family that I developed to help facilitate learning that has kind of intentional placement in our curriculum as we take care of students. So students might take care of the baby one week and the grandpa the next week, depend upon, in the curriculum, what it is that the learning needs are at that time. The nice thing about a genogram, this is kind of a really big one, it shows all 65 members, but it provides the relationships between family members, and it shows disease processes, genetic kinds of codes, if they have like a hypertension in their family or diabetes, or maybe they've got a BRCA1 gene for cancer. Those kinds of things can be shown in a genogram. So it's very helpful for healthcare providers to see that whole family unit kind of shown in a picture format. It makes it easier. So now that you know a little bit of background about myself, let's kind of get into the research itself. In 2016, we had a team of 3 that published this first version of Van Gelderen Family Care Rubric as part of my doctoral dissertation. The study was a convenience sample of about 97 undergraduate nursing students at MSU, Minnesota State, where I work. Although the rubric was found to be reliable and a valid tool in 2016, it had not been tested internationally or with practicing nurses, or used from a peer review perspective. So this was kind of our next feat that I really wanted to. So an international study with a peer review integration and testing it with practicing nurses and midwives was kind of the next feat we wanted to undertake. I met Dr. Amanda Garro at the International Nursing Association conference in Pamplona, Spain in 2017, I had reported on the rubric during that conference and asked audience members to undergo an international research project. And Dr. Garrow had volunteered and came forward, and together we built a 4-site international study across the United Kingdom and the United States. And it grew into a team of 7 researchers, 4 of them from the United States and 3 of them were from the United Kingdom. So now a little bit about the purpose of the study of this particular one was really just, again, to validate the evidence-based Van Gelderen Family Care Rubric so that nurse educators and peer reviewers could use it to objectively evaluate nursing staff, students, and just really build communication and family care skills while offering really consistent and good feedback. So we have kind of a little bit of background about family care in general. Family care is recognized as a best practice because there's evidence to support that when nurses and midwives provide holistic family care, patients really do have improved healthcare outcomes. It reduces overall healthcare costs, and it improves health-related quality of life. So family care is really recognized as best when caring for children and their families, but a lot of times we don't have very much opportunity for inexperienced nurses and midwives to develop the skills necessary to provide this care. So a critical component of skill development is really providing consistent feedback to help develop family nursing practice. And when I first started this, there really was no evidence-based tool to help educators measure nursing actions and frame feedback. And so that's how I ended up developing the Van Gelderen Family Care Rubric, was really out of a need to help provide consistent feedback to learners. And that was important to me to help build performance and competency. So with the increased use of simulation, it's really led to a demand for reliable and valid evaluation tools to help measure learning. And so this has really helped provide a solution for that gap. So, Dr. Garrow and I were really purposeful about which sites in the United States and the United Kingdom we sought after for our study. Our total sample consisted of about 210 students, nurses, and midwives. And of those 210 participants, about 165 were actually scored with the Van Gelderen Family Care Rubric. So this really is quite a large study. Some are just more observers, just evaluating using the tool on their peers, but they were not evaluated themselves. But of the 210, 165 were scored. So we had a lot of data within this study, which we're really quite proud of. So the 4 U.S. researchers were Ashley Ingebretson, Sabrina Emke, and Marilyn Swan. They're all university professors and work within Mayo Healthcare System. So within the United States sites, we tested the rubric with nursing students as well as obstetrical and pediatric and neonatal staff nurses. The staff and students completed the same. They had 3 obstetrical and 3 pediatric emergency simulations that we used consistently among all research groups across the United States and across the United Kingdom. So they were all the same. And for MSU, we served as a site that we tested the rubric with the nursing students and obstetrical nursing staff. At MSU, we utilized high fidelity mannequins to birth the babies. They had obstetrical complications and care for the neonate. A lot of CPR was needed. Additionally, we used like a standardized patient or an actress, as you can see there in the picture. We hired her to serve as a patient with autism who was needing an appendectomy. So we really felt that needed to be more coming from a person rather than a mannequin, to show some of those mannerisms that autistic children have. We found that very helpful as well. At Children's National Medical Center was one of our second U.S. site, and that served as a site where we tested the rubric with 25 pediatric intensive care unit and neonatal intensive care unit nurses. Dr. Amanda Garrow had led the simulation center there at their medical center, and the facility was recognized as the #1 NICU center in the U.S. And so these are really high performing PICU and NICU nurses. They had completed, again, the same pediatric scenarios as the University of Salford and Manchester children's nursing students did too. So again, kept that consistency among the sites to keep that rigor within the study itself. Here, we are at the University of Salford in Manchester. So this is one of our UK sites. And here we utilized a high fidelity mannequin to play the role of the patient with the children and the nursing students. And we also used a standardized patient or actress to play the role of the patient, again, with the autistic child. And we hired a actress to serve as her mother and play the role of the mother. And I just really learned a lot about the different healthcare systems. We completed this study from 2018 and 2019 when I was on sabbatical, and it really offered me time for travel to work in really with a long time in the UK with these other researchers, which I'm very grateful for. And I noticed some differences in some of our educational settings. For instance, on the left, you can see that we use like a traditional electronic medication card. It's called a Pyxis. And our students use this at the university that we're at. They use it in the healthcare system, and you need fingerprinting to get the medication out. On the right-hand side, you can see a medication card that we used at with the Salford students, and that's how they got their medication out. And so I really learned within my international travel and the research itself that, although we have different equipment within our simulation centers, I learned that you don't really need a lot of bells and whistles to provide a really quality simulation education experience. So I think that's really important too, is that you don't need all the fancy stuff to have a really good education time and experience for everybody. So at Keele University was where we worked with midwifery students, and we tested the rubric with 23 of their midwifery students. And here they don't have high fidelity computerized mannequins. They didn't have that. And so instead, we use what's called a low fidelity simulator, and it's called Mama Natalie. And you can see this up here in the upper left. We hired an actress to serve as the mother birthing the baby as the students cared for her. And we also hired another person to play the role of her significant other. So we had a lot of great experiences for these students. Here you can see what Mama Natalie does. She has like a placenta and umbilical cord. You can see the baby being birthed here. When the baby comes out, the umbilical cord and placenta comes out. And we use this mannequin to show eclampsia issues, shoulder dystocia, and postpartum hemorrhage. So we had fake blood, all those kinds of things coming out of a very low fidelity, very cost-effective simulator, and a great actress that served as that role. When I was working in the United Kingdom, with a midwifery researcher, one of our researchers, Dr. Angela Hancock, I learned that there's really a vast difference between pain management during labor and delivery between the United States and the United Kingdom. Dr. Hancock had reported to me that about 80% of births there are managed by midwives. And about 20% of those women utilize epidurals or spinals for labor. And that's a really stark contrast in the US. Really, here in the US, we kind of typically I also found it interesting that there were midwifery wards and then OBGYN wards in the hospitals. And in the US, you don't really usually find that. It's more of a medical approach, and OBGYNs are more utilized compared to midwives. And I would say our epidural spinal rate is probably 80 to 90%. And so it's much higher as compared to the UK. And I think we really have higher morbidity and mortality rates with mothers and infants. And I think that's something that we need to take notice. Our educational system, and another really difference in our educational system between the United States is that all nurses in the US are trained or educated as generalists, either from a 2-year or a 4-year degree. And then from there, they specialize into various areas such as obstetrics or pediatrics or mental health nursing. To become a midwife, for instance, within the US, you're required to become an advanced practice nurse that has gone on for their master's or doctoral degree. So it's considered an advanced degree in the US. Again, a little bit different between Europe really and the US. So an interesting observation that Dr. Angela Hancock had while working within the research project was really showing how Nursing and Midwifery Council has increased their emphasis on family-focused care. In 2009, they made 27 references to family, but in 2019, they cited 107 references to family. So it's really clear that midwifery and nursing care is recognizing that when the whole family unit is supported, the patient is supported too, and the whole family unit really has better healthcare outcomes in the end. So now that you kind of have a good understanding of the various research sites and samples that we use in the simulation settings and how we set up those scenarios, I thought kind of give you a little bit of a background on the rubric itself for those of you who are unfamiliar. So Van Gelderen Family Care Rubric is really comprised of two domains. We have family communication and family assessment skills, and really what we're trying to figure out here is showing learners that they're evaluated and given that formative feedback based on these 12 constructs. So 6 communication, 6 on family assessment. And we feel that all 6 of the family communication side can be measured each time a learner is interacting within a simulation setting or within a family encounter in practice. Whereas an evaluator should be more purposeful about which of the family assessment skills that should be measured for each scenario. We're recommending like 1 or 2 family assessment skills that could be shown here, and it, because they do take more time, and so it would be kind of too robust to expect within one simulation scenario that all 12 constructs are measured. So educators need to be purposeful, really, like I said, all 6 on the communication, but just pick 1 or 2 about the family assessments. I'm going to show you what that looks like. I'm going to slide it over to my other here. So this is within the article itself, 2019 article. You can kind of take a look at that when you have time if you're interested in learning more, but I thought I'd just kind of give you a real brief overview about what the rubric looks like. So here you can see that this is the first of the 6 communication skills, and it's really based on a 3-point scale. So 3 being that, the learner did very, very well, down to 1 where they need more direction and support in learning to build those skills. So the first one's just talking about communication style, how fluid and open that their communication is with the family and patient. And the use of terminology that kind of really needs to have evaluators and peer reviewers kind of have a conversation about before they start the simulation. How will I give you that feedback so we are consistent? So use of terminology might be like, well, if the nurse said the word void, to me, that's a medical term. Like the family wouldn't understand the word void. We should say, did you urinate, or vital signs. I mean, do you consider that a medical terminology? Should we be more talking like blood pressure or, be real specific? And if we use medical terminology, are we backing it up with some definitions so the family and patient are understanding what that means? So this is really a conversational piece that needs to happen before people are utilizing the feedback or the rubric, so all feedback is consistent. Just talking about positioning with the nurse and midwife, how they're positioned with the family. Do they have their back towards them? Are they talking at their level? Some basic communication things. I mean, for us, some of us, it feels very basic, and for others, it's a learned type of activity that we need to, really talk to them about. So eye contact, what's respectful in their country? Is it looking down? Is it direct contact? Whatever that might be. And just really providing compassionate care. Are they providing support to the family and hope and giving them guidance? And the summary and validation, now this was the add-on that this new group of 7 researchers felt that it needed to be added on. In the 2016 study, it was not. We had 11 constructs. And so this was a new one that was measured for the 2019 study. And it's really about, once we're done with our encounter with that patient and family in the room, it's kind of a way that we're encouraging healthcare staff to really say, verbally reflect back what you heard and what the conversation was about. So we're all on the same page and say, when I leave the room, I'm going to do this, I'm going to follow up on this. That's the kind of things that we're looking for here. And then we've got on the second page, these are the family assessments. So these are the 6 that I would say you pick 1 or 2 to measure per simulation scenario, or if you're in practice measuring these things. So don't expect them to do everything, that would be too much. So things like family, collecting family history and data collection. You could use a genogram or echo map to genetic code that health history, that pictures speaks 1,000 words compared to a long document. how family health routines are measured or done in the family. For instance, if you're taking care of a child, if their nap time's at 2 p.m., well, let's not schedule medications or treatments during that time. But, just being thoughtful so they have time to heal, time to grow, and make sure that we're abiding by their routines. Things like addressing family needs, what are their issues, what are their concerns, do we need to provide some resources for them before they leave the hospital or working with them in the home? What support and teaching do they need? And are the nurses and midwives providing that teaching? And then really addressing what we're doing as healthcare professionals. How much do you want me to be in helping you make those decision processes for your healthcare? Do you want me to just give you the information and you make the decision? Do you want my professional opinion? How can we aid in their healthcare decision-making process is really what that's about. Okay, we'll go back to the PowerPoint there. All right, so that's the rubric to give you some background on how people are being measured. So we had two hypotheses for this study. The first was that we felt that there would be really a greater overall average score for participants that were involved in the pediatric simulations compared to the obstetrical simulations because of the complexity and emergent issues of the simulations in the obstetrical versus the pediatric simulations. We're kind of measuring really emergent issues in obstetrics and less emergent issues in pediatrics. We wanted to compare and contrast that. Secondly, we felt that there would be no difference in overall Van Gelderen Family Care Rubric average scores by researchers in comparison to the participants as peer reviewers. So remember that this was the first time that the rubric was being measured from a peer review perspective, where it's tested both by researchers and by peer reviewers for feedback. So we had a total of 11 content experts that reviewed the constructs within the tool itself, within the rubric itself, and really measured for content validity and face validity. We did a really robust literature review again, because there was a gap between 2016 and 2019, so we wanted to go back in literature, make sure we didn't miss anything, and that's where we surfaced the summary and validation construct. We felt that needed to be added to the tool at that time, as I described earlier. And so, like I said, there was 4 simulation centers at the 2 international sites. We had that purposeful sample sites and sample size that we wanted to do. And I served personally as a chief investigator and ensured that correct study and procedures were coordinated between all the sites and making sure that appropriate organizational research permissions were met. And then those were done by each of the individual principal investigators at each site. So we kind of made sure that everything was being done appropriate as we got going in this international study. All of us had consents were obtained. Student participation was voluntary, and no students were graded or had the people that worked with them had any kind of grading authority over them. So they were welcome to participate or not participate. And so participants were asked to care for simulated mannequins or actors who played roles as patients in simulation suite. We had 6 simulation scenarios, 3 obstetrics and 3 pediatrics, and we didn't place any time limit on the participants. When they were done, they were done. So we had set up the simulations. They were live streamed to a separate room and a debrief room where we had the peer reviewers watching as it was happening. And each of the peer reviewers independently scored their peers that were doing the simulation and the participants, and then they came together afterwards and talked about it as a whole, and more feedback was given. Additionally, we had done a pre-survey, getting some demographics on all of our participants, finding out what their knowledge was about family care in general. And then we also did a simulation evaluation at the end about their anonymous survey, just tells about their experience and how they found that their learning went and how we facilitated things as well. So we had 7 nurse researchers that independently scored the recordings. All data was compiled, 100% of the data points were verified for accuracy. And so then we gave our results to the statistician who then scored it for us. We had 2, one instrument specialist and another that was a statistical person. So I found that for internal consistency, we used the Cronbach's alpha, as you know. The researchers, we found that there was internal consistency with the 12-item family constructs that was determined reliable with the overall Cronbach's alpha of 0.842. You see highlighted there at the bottom. And then for inter-rater reliability, we used the Fleiss-Kappa statistical test that was used to determine the reliability because we are using ordinal values. So 11 constructs showed significance at the p equals 0.05 level. The construct of summary and validation did not show significance with the participants, but did show significance at the 0.5 level between the researchers. So this table kind of demonstrates the first hypothesis was supported by showing the pediatric sites did have a higher score compared to the obstetrical sites. This really indicates that, with less emergent situations, provides more time for family care to be provided during those pediatric simulations comparing to the obstetrical simulations. Hypothesis 2 was supported by showing that there was no difference in the overall family care rubric scores between the researchers and participants. This was demonstrating consistency in scoring across different users. This was very exciting for us since we had never tested it before. And it just shows how high value it is between educators and being consistent among participants and peer reviewers for measuring family care and communication skills. So overall, we found that the rubric was reliable and valid instrument to assess nursing and midwifery students. We found that, we were able to identify, through midwifery students and nursing and staff, we could find that we were able to help their family-focused care actions and communication skills and help to apply that to their future practice. So, like I said, it was really important and exciting to see that there were no differences found between researcher and participants' overall scores of the Van Gelderen Family Care Rubric. So this consistency is really, valuable and it shows utilization during debrief following simulation by helping participants to raise awareness of their strengths and areas for improvement through that formative feedback process, and really from an educator-led and that peer review perspective as well. So, we need continual refinement of the rubric, the constructs. We have some inter-rater reliability. There's 3 of them that were a little bit on the low side. The use of terminology is like one of those that something really needs to be talked about in advance, what we consider medical terminology and what we don't. Family health routines and addressing involvement, partnering with family were 3 of the constructs that were on the low side. So they can still have a more refinement. So a factor that may have lowered the inter-rater reliability with the obstetrical simulation scenarios was that it was in an acute, high intensity emergent situations that may have given the participants really less time to tend to the family needs. And so that may have skewed the raters scoring a little bit with the intensity of the situation. And it's just really important for educators utilizing the rubric to discuss behaviors that constitute how we will score, so we maintain that consistency beforehand. So again, no single scenario could address all 12 constructs at once, but by providing three scenarios throughout their learning experience, they had the opportunity to really show all 12 constructs so that all of them could be measured. So with the rubric, it just really shows how it enhances development and broadens the focus of simulation for communication and family care skills. And we have now shown that it can be used internationally and utilized within several different simulation settings and different fidelities and modalities, whether it's high or low fidelity simulators, it can be utilized. So we found that by allowing nurses, again, more time at the bedside, less emergent care, more family care was provided. And thus, nurses were more likely to include family in these care situations depending upon their perceived thoughts about physiologic needs of the patient themselves. So this supports that when nurses and midwives have workload assignments that can provide time to engage in meaningful care, we can really shift our focus and help both the patient and the family. And we just find that when the rubric itself really enhances that and broadens our psychomotor skills and ability to address family communication and care skills. So Of course, future and current research education still needs to continue on. As Timmy described earlier today, it is now, the rubric is being used in 9 countries. We have the 9 countries that they're being used in is Japan, Saudi Arabia, Ireland, Spain, Brazil, Canada, South Africa, United Kingdom, and the United States. So it's pretty exciting how many countries are now jumping on board and testing the rubric and utilizing it for educational purposes. There are 4 current research studies that are being conducted. Excitingly, University College Dublin School of Nursing, Midwifery, and Health Systems is embarking on a longitudinal study utilizing the rubric, so I'm very proud and happy to be working with you all. We have a study happening in South Africa and also in Navarra, University of Navarra in Pamplona, Spain, has transcribed the rubric into the Spanish language. And then in the Federal University of Sao Paulo, Brazil, they're utilizing the rubric and just starting to transcribe it into Portuguese. So that's pretty exciting too, that now the rubric will be available in 3 languages. So to conclude, the rubric has really provided, a great framework for engaging nursing and midwifery staff and students in developing communication and family skills. It continues to provide educators a teaching guide to aid in development of those skills for family nursing practice. We found that the rubric itself was really a valuable asset used from both peer review and researcher perspectives to help, again, them learn those essential skills. So we're proud to say in 2019, our international research study was published by Clinical Simulation in Nursing Journal. You can check it out there if you're interested in learning more. And as Timmy described, we were recently awarded from the Society of Simulation in Healthcare that we received, one of the articles of influence. And then the rubric is also listed on INACSL, which is the International Nursing Association for Clinical Simulation and Learning. So again, very proud of those accomplishments for our research teams. I've got some references there for you if you'd like further. I just kind of wanted to extend it at this time. Just a special thank you to UCD and Timmy and Suja for inviting me as a guest speaker and spend time with you all today. And I appreciate your time and attention. I'm open to questions, comments, and anything you guys would like to discuss.
Sure, and thank you, Stacey, for such a comprehensive presentation. I feel you really honed in on a number of key areas, including, of course, the research itself, but also it was really encouraging to see what simulation in the US looks like. I think the pictures really brought some of that to life in the high fidelity simulation which you're leading out on over there. In addition, the impact and influence of family-based nursing, how that's grown over the last decade or so, I think was quite instructive. And fundamentally core to nursing, midwifery, and indeed all of healthcare is communication. So regardless of the specific area of focus, I think the communication elements are so important to embed within our curricula. I would like to just say thank you prior to opening it out to others, but also just to acknowledge the good turnout from colleagues here at the school and elsewhere. I noticed that our Director of Simulation, Siobhan Brereton, is in the audience, and also our Dean and Head of School, Jared Feely, was in the audience a little earlier, and I noticed some heads of subject are here with us as well, alongside many esteemed faculty and friends. I just see, actually, I think I see a question. I see a question here from John. This would be John Gilmore, assistant professor in the school. So I'll just read it out, Stacey, and if you want to field the question. So thanks a million again, Stacey. Always a pleasure to hear from you. Just thinking of applicability in adult-centered settings, I'm wondering whether Van Gelderen Family Care Rubric presupposes the primacy of the family as the structure for optimal well-being. Interested in the flexibility of the term family. If using tools like genograms and interest in family history, it would seem the focus with the VGFCR is more biomedical rather than psychosocial. How might this be considered in adolescents or adults where isolatory life might be a preferred choice? Thanks, John, and I'll hand over to Stacey.
Well, I think, you know, if their, you know, preference is to be by themselves, a family unit, I think that we can still utilize it from the patient perspective alone, as well as an individual, as a client that we're working with. We certainly can use the rubric, whether it's tested in within the family unit itself, or just really from it, we are checking for patients as well, and how we're addressing. The tool kind of goes through about, we were just really directed on patient alone or family. Of course, they'd be scored lower on the rubric, since it is a family care rubric that we're trying to include all members. And if they are in isolation, and that's their preferred choice, it really could be utilized from, are we addressing their needs? Are we making, helping with their resources that they need when we're working with them in the healthcare setting, whatever environment that is. So I would say that, you know, the tool itself really is geared more for more than one. But I think there are applications to teaching, even just this first six, the communication skills side of it certainly could be lent to any situation as an individual or an entire group of people, so to speak. So I think from that perspective, that the first six of the tools certainly could be utilized, and maybe some adaptations on the back half with a larger than one kind of group could be utilized too. And the idea of a genogram is still helpful from a genetic standpoint of the individual. And so those kinds of things could be applied to a person in isolation. And so that, I think, should still find value.
Thanks, Stacey. So just to say, Justin can facilitate people in discussing or speaking as well, which would be great. And of course, there is the Q&A function.
Sorry, Timmy, I just want to highlight how important to work on family nursing. Myself and Stacey, very active members of International Family Nursing Association, which is, we have almost 500 members across 35 countries. This is the only international family nursing organization where focusing on lifespan, across lifespan, family health across lifespan, through education, research, and policy and practice. So anybody's interested, and I would really encourage people to join. I know many of my colleagues from UCB already joined, if not UK Ireland chapter. I know Timmy yourself is also part of that group. So that is really embedded in our School of Nursing, Midwifery and Health System, the family nursing concept. So again, I witnessed how do you know, my time with yourself, Stacey, in the National Children's Hospital. And I was able to see how the facility they had in the Children's Hospital in terms of simulation and the simulation suite, and how this all worked well in terms of people working in the clinical settings, the communication, and we all teach different communication. Hello, my name is, what matters to me, even is bar, but everything put it together as a pack. And then we are including this family assessment care skill to embrace their knowledge and skills. And I was very pleased. And that's the reason I came back to the university, spoke to Jared, the head of school, a number of head of subject, and really thought will be really beneficial for all the program. I really want, to my personal level, I really want to thank you, Stacey, for coming on board and supporting the research program here we have in the school. I know Shivani is here. Shivani is our director of simulation. So I'm going to hand over to Shivani and see whether Shivani would like to ask any questions.
Yeah, I just have my hand up. It's a comment really. So Stacey, this is really interesting, and you know, I've been involved, and I think, you know, as Suja said, communication and communication skills are so important in every facet of what we do. And I teach patient safety, and I do some lectures around, you know, patient safety and communication as well. But I think the rubric, definitely, I can see, I just maybe had a light bulb moment today. I could really see where it could sit within the general program more so today. I was having a little bit of difficulty with that. I can definitely see around obstetrics and children's nursing as well. The comment really that I wanted to make as well, I have to say I'm envious of your facilities in your university. but we're making strides here. We'll get to high fidelity simulation and hopefully sooner rather than later. But the point that I wanted to make, I found it really interesting in your study that the rubric was found to be valid with varying simulation fidelities. And I think that's a very important point to make around simulation. As you said yourself, we don't necessarily need all the bells and whistles. It's lovely to have them, but we can use task trainers very successfully in that way. So I just wanted to make that comment. So thank you very much.
You're very welcome. And you know, I am in a privileged facility. It really, and not all U.S. centers look like that. I mean, our facility really is state of the art, so our students are very lucky to have their education there. But it really was very impactful for me when I went to Kiel, and you know, we used that Mama Natalie, and it was a $300 US mannequin. It was very low cost compared to a $60,000 to $100,000 US mannequin. So a vast change. Of course, the caveat there is having somebody to play the role of the mother, whether that be faculty or a volunteer. I mean, I had funds for the study to hire actresses and actors to play roles, and I don't have that normally. I mean, that was a grant that I had received, and so oftentimes what we use is I actually pull the students. I pull the students aside, and they each take a time. And I'm very purposeful within the simulation scenarios, like I've shared with your faculty there. I'm purposeful. I pull them aside. I say how I want them to act, what I want them to do. I give them cues. I don't let them take their sheet of paper in there. Otherwise, they hold it up like this. It's like, no, just roll with the flow. What do you think you'd say? And it can be a very educational experience. And oftentimes, I found the standardized patients, those actors, those volunteers, probably did better than our $100,000 mannequin. So. I've started to do some talks about how to do simulation on a shoestring budget. I mean, you really don't need a lot. When we were in Kiel, like at our facility, we have the top-down cameras and videos. We're able to zoom in and get in, all that kind of stuff. But at Kiel, they didn't have that. And we used Google Meet, I think it was called Google Meet. And we had a laptop facing the patient and seeing the whole room. And then we had another just regular video camera showing the other way that we were just recording for research purposes, just really the face of the nurse and her nonverbals or his nonverbals. So we had that for research purposes. But from the live standpoint, it was a laptop on Google Meets, and it was broadcasted live to the other room and recorded. We had everything we needed, and we didn't need the fancy stuff on the ceiling. So, it really can be any frame, any environment, any tool. It can be done, and it should be done because it really supports the learners that we're working with. So important. So I'm glad you raised that point. Thank you.
Looking at Justin, I know, Justin, you recorded us today. Do you want to say anything, Justin? I know you recorded a family care rubric style scenario with the staff.
I recorded yesterday. Suja wasn't able to attend the last minute, so I can relate to exactly what you're saying, that you mentioned there about Google Meet, and I just even put in to the panels there, as the AV guy in the school. It's not about the expensive equipment, it's about the functionality. So long as you can get something that works for the students, I think that, and I echo what Siobhan was saying there, so long as the functionality is, and it provides what the end user needs, that's the most important thing.
Yeah.
Sure. Thank you, Justin, and thank you, Siobhan, for your really insightful comments as well. And just to build another question, and thanks again, John, for your question earlier. Here's another one from Francis, and this is Francis Howland, Assistant Professor and Head of Subject for Children's Nursing. Stacey, thanks very much for your presentation. I really enjoyed it. Can you comment on how the child-centered care fits into the family care rubric?
How child-centered care? I think the child-centered care is all about the rubric. I think that, it was interesting because when Amanda Garrow, one of our researchers from the UK, first attended the IFNA conference, the International Family Nursing Association conference, what she originally thought was that it was pediatrics, like a pediatric or children's, you guys say children's, we say pediatrics, a children's conference was what she thought was family care. And I think internationally, that's what family care maybe is to some people. But I think we're trying to get the word out that family care is any area that we work in healthcare, whether it's with our elders or working with neonates or pediatrics or wherever the care setting is. We ought to be inviting the whole family unit, because who takes care of that patient when they go home? It's the family, right? And if they don't have the resources and they don't have the tools or the education to help them to be healthy as a whole family, you know, our preventative medicine, our health, our nutrition, the things that many of us who, you know, have money take for granted, right? When we have those resources in place, we're gonna have healthier individuals, we're gonna have healthier family units, we're gonna have less readmission rates, less healthcare costs. So when we support before they go home, the tools that they need, the education and support that they need, we're not, you know, really in the US, we're starting to have case managers within the hospital setting that makes the phone calls to families who are reoccurring, patients who are reoccurring all the time in the hospitals. And by giving them the education, extra support, they're not coming back as often because they're healthy. They're not having that chronic healthcare condition. So from a children's standpoint, to me, that's kind of like the base of where this kind of stemmed from is really how do we support that family so when they go home and take care of their child, that they have what they need. And, you know, we have to have that basic communication skills as healthcare providers. We cannot be using language that families don't understand. Just get down to the nuts and bolts of why we're here to care for others. And, you know, and to show what, you know, by using that genogram, for instance, I can see quickly what the family echo map, actually, I didn't show that today, but it shows resources from the family standpoint. What are they connected with? Are they connected with a church? Are they connected with healthcare providers? Are they connected with support groups? What is in their area that maybe they don't have understanding that there is that resource or that free resource that they can get that support and help from a community health public health standpoint? Where can we direct families so that they're cared for? So I feel that, you know, this rubric is transfer, you know, wherever can be utilized, children or adults or wherever we're working, just building these skill sets with healthcare workers will just help our world, right? Help our world.
Okay, thank you, Stacey, and thank you, Francis, for the question. And I also see some words of praise from a colleague based in the India Institute of Medical Sciences, and thank you for that. Just to check if we have any more questions, because we have 5 minutes left.
I think
sorry, Stacey. So I've been contacted by one of the biggest institution in India. It's called All India Medical Institute. I only had the conversation last Saturday, and they are developing some simulation as well. So they will be very keen to talk to you as well, because they are developing a big simulation suite, and they are also looking for a grant to develop simulation. So that is something I will able to introduce yourself. I think simulation is something beyond any countries. I think it's a needed for everybody, you know, the simulation and simulation focused teaching and education. So, and I just want to say, Dr. Catherine Redmond is actively involved and engaged in the program, but she's unable to join us today. So just want to say, you know, her apologies to you, Stacey.
No problem. And I think one thing in my conversation with Suja and Timmy and their UCD faculty, we had a conversation a few weeks ago about what is the definition of family. And when I'm looking at research, I really look to like Wright and Leahy, Lorraine Wright, and when I look at their research and what they talk about, my favorite quote is, "The family is who they say they are." It does not need to be blood related, okay? It might be their neighbor that is more close to them than their parents or siblings who might live 3-4 hours a country away. And so the family unit is whoever that person says is their family, okay? And so, that was really impactful to me, to get out of the traditional nuclear family perception, and just who they say they put on the genogram, whether they're blood related or not, that's their family, that's their resource, that's the people they go to help. And so I think we have to be more open-minded about what family is, and just be respectful of that individual's, whether it's being isolated to themselves or being within a group. That is their circle, and that is what their choice is. And so we should be respectful of that as healthcare providers, to honor that, and to be helpful in any way that we can.
Okay, thank you, Stacey and Suja, and thank you, Asha, for your comment also. Any other questions before we wrap things up? Stacey, just a quick question from myself. If a school of nursing, midwifery, and health systems, for argument's sake, were to invest in one of the high fidelity models or more, one of the more expensive models, how could such a school get maximum benefit and value from such an investment?
That's a great question. I'll give you an example. So we had funds. Our simulation center was just built in 2017. Like I said, state of the art. We're spoiled rotten. I'll be the first to admit. But part of what we went to when we went to our state, so we're a public institution, when we went to our legislators, to our, the people who represent us from within our state, we said, we want to provide a center that is going to educate not only students in our public, but educate all healthcare staff. And so what happened is that we have what's called a workforce grant. And so we went to our state, to our government, and asked for money and said, we would like to build this building. We would like to invite healthcare industry to come to our site, to utilize our mannequins, to use our in a partnership. And so that we do have many Mayo Clinic Health Systems in Mankato comes to our university. They utilize our space, they utilize our mannequins. And we have that relationship where we are able to do our clinicals with our students at their hospital. And so that's an example of where we're having a partnership. Just recently, we had one of our simulation suites converted into a surgical suite, and Mayo donated some of their older equipment that they're no longer using, put it in that space, and now they're bringing in their staff to educate about surgical expectations. And so how their teamwork, their processes, all those things are done at our campus. They don't have space at the hospital. And so when we have some of those partnerships built, going together in a joint grant is much more meaningful than from a school by themselves. And so I would encourage you all to maybe go together, reach out to your clinical partners and say, hey, let's do this grant together. We're going to try and get this $100,000, $60,000 mannequin. We'll house it here. We'll work together on providing time to utilize that resources. So when you combine things, it's helpful.
Okay, so thank you, Stacey. And indeed, you're right. Teamwork, collaboration when it comes to grants, and of course, the more often something is utilized, the greater value it represents. So I guess on that note, we'll draw things to a conclusion. I'd like to again thank the organizers for this afternoon. In particular, I'd like to acknowledge Justin Dawson, our AV professional in the school, who as always brings a frisson to proceedings. And again, thank you, Stacey, and all of our international colleagues who, we have a deputy prime minister who had a phrase. He's called the Taoiseach in Irish, in Gaelic. He had a phrase about people who get up early in the morning, and certainly, Stacey, you get up early in the morning, so I suspect good things will be happening for you. So thank you so much for joining, and thank you to all of our colleagues for dropping by this afternoon. It's been a pleasure.